Thanks, Jill. Thanks for asking me to come down and speak. I feel at least partly responsible for some of the anxiety in the last 48 hours that I've just heard about, because there were some panicky emails saying, Matt, have you sent your slides? Have you sent your slides? And I'll be honest with you, I didn't send them till about 9 o'clock last night. So I take full responsibility for some of that panic. But it's tremendous to see so many people here. I didn't really know how many people to expect, but I understand there's about 180 people who've registered to come to the seminar. So that's amazing. Would anyone mind if I just take a picture from this point of view? Because if I go back to Manchester and tell my colleagues that I had to come and give a talk about frontotemporal dementia, they'll be like, oh, who turned up? 18 people? And I'll be like, no. It's a real thing. So there we go, that's good.
So if anybody has an issue with that, please let us know.
So I was asked to give an overview of frontotemporal dementias. So I prepared the slides a couple of weeks ago, which makes my excuses seem more terrible, really. And then actually, shortly after I'd been preparing the slides, there was a bit of publicity about frontotemporal dementia. So I don't know how many people got to see this documentary, which was written and put together largely by David Baddiel, who's a comedian. And actually, when I was a teenager, when I was at school, David Baddiel was a really famous comedian. I remember going to see him live. And bizarrely now, he's sort of a writer, and my children read his books, which is quite odd. And then he popped up on television doing a programme about a disease that I sort of study and see patients with. So it's all very strange. And I sort of approached it with a bit of trepidation, really, as I do when there are television programmes or films or newspaper articles about a disease that you're really interested in or invested in, because you think, oh, on one hand, good, it's going to really raise the profile, that's excellent. But then on the other hand, you think, well, what if it's really bad? What if it's wrong? What if they show somebody with frontotemporal dementia, you don't think they've got frontotemporal dementia? Or that the message is just a little bit different to that which you give to your patients and the families. So I watched it. I watched it on catch up, and actually, you know, overall, I think I was relieved. I enjoyed the programme. It was a very personal portrayal of how a dementia had changed someone's relationship with their father. But it did raise up a few interesting points about FTD, I thought. There are quite a few troubles with FTD, not least of all some of the naming problems around what do we call this illness. Because I think most sort of neurologists and probably most psychiatrists in the UK call it frontotemporal dementia. And we all routinely abbreviate it to FTD. Across the pond in the States, they normally call it BV-FTD, or behavioural variant FTD. You do get some people calling it frontal lobe dementia, which obviously sounds pretty similar and isn't that confusing. So that all, I think, makes sense. You do still get some people who refer to it as a non-Alzheimer dementia, which I think is less helpful, because that's only really telling us what it isn't. And actually the Trouble with Dad documentary referred to the illness throughout as Pick's disease, which is what I think traditionally the illness was called, actually. A lot of people have moved to calling it frontotemporal dementia, but it's certainly still routinely known as Pick's disease in many circles. And occasionally you hear sort of slightly more scientific-y sort of terms such as frontotemporal lobar degeneration. So certainly knowing that, you know, all of these words essentially probably mean the same thing is important, but actually having so many different names for the illness almost doesn't help. The other trouble with FTD, which this documentary brought up, was that, you know, there are some real issues with it. It's a very, very variable disease, actually. And when I was looking at David Baddiel's father and some of the other patients who were in that documentary, I thought, yeah, I do recognise some features here that I see in my patients who've got FTD. But actually, overall, I thought he wasn't particularly representative of most of the patients I see with FTD. And one of the messages of the documentary was that this illness had really exaggerated his father's personality, that he became a caricature of himself. But actually, when I speak to my patients, or more accurately sometimes the patients' families, what they tell me is he's not like the old person at all. He's changed to a different person. So I thought, you know, there's a good deal of variability in this condition, and that's one of the reasons why it's such a tricky customer, actually. But nonetheless, you know, I think the documentary was good. It did raise awareness, and it is what it is. It's a very individual portrayal of that family's struggle with FTD. The other trouble with FTD is more generalised and not really related to the television programme. It is quite a rare disorder compared to other dementias. So compared to Alzheimer's disease or compared to vascular dementia, this is a rare disease. It's quite hard to spot. It's traditionally considered quite a difficult diagnosis to make. And that's because the symptoms are to do with the way people behave, often quite subtle changes in social interactions and social behaviour. And there are lots of reasons why people's behaviour can change. It doesn't always have to be a disease like FTD. And the other trouble with FTD, I think, is that it's a very different sort of dementia to what most people in the general public perceive dementia to be. Often, if you ask somebody at random about what dementia is, they'll say, well, this is, you know, probably something that affects someone old and they become forgetful and maybe they become quite frail. But actually, a lot of the people I see with frontotemporal dementia aren't very frail. They're not very old. They've got pretty good memories, but yet they're still really struggling and their families are really struggling with their dementia. So there's a lot of trouble with FTD. And people find it a difficult topic and it's complicated. So what I'm hoping to do in the next few minutes is really take a very much back to basics approach. Because I think actually if we just go back to thinking about what the brain does and therefore what might happen when certain bits of the brain don't do their job properly, it makes this illness a little bit easier to understand. Now, I spend a reasonable amount of my time teaching medical students or trying to teach medical students about the brain. And they find this terrifying. And frankly, it's hard work trying to get medical students to understand the brain. But what I'm hoping to do today is really have you as my seminar group today. You're going to be my students, and we're going to go through a little bit about what the brain does and what might happen when the brain goes wrong. So I'm fully expecting you to be a level above what the medical students are like, because you're all here by choice. You're all interested and invested in this topic. So I'm going to start from three basic principles. So we know that certain brain regions perform certain tasks, and we know this for lots of different reasons. There have been lots of different ways of studying this over a couple of 100 years, but basically we sort of know which bits of the brain do what. We also now understand that certain diseases will target specific bits of the brain. They don't normally affect the brain at random. That's quite unusual. So certain diseases will preferentially target certain brain areas. And as a result of that, predictable patterns of symptoms will emerge. Now this is very helpful from a doctor's point of view, from a neurologist's point of view, because you can reverse that. So when a patient comes to you and their family comes to you and they describe symptoms, you're then able to infer which bits of the brain must be going wrong. And when you know which bits of the brain are going wrong, you can go to your list of illnesses which typically affect that bit of the brain, and hence make what you hope is an accurate diagnosis. So we'll just go through it sort of bit by bit. This is a heavily simplified version of the brain, and we split it into lobes, and the biggest one is the frontal lobe. That's at the front, as the name suggests. You've got the temporal lobe on the side, the parietal lobe is towards the back, and the occipital lobe is right at the very back. And as I said, we pretty much know what these bits of the brain do. So we'll start with the frontal lobe. That seems only appropriate given the topic for today's seminar. Most bits of the brain, most lobes of the brain have got what I would call a primary function. It's maybe not the most important thing, but it's something that is always in the same place in everyone's brain. And for the frontal lobe, it's movement. So the control of movement, your motor function, your arm lifting up, going back down again, that's controlled from this bit of the frontal lobe. The frontal lobe's also got an incredibly important area to do with speech. And it just so happens that in most people, it's on the left side of the brain, in this sort of oval-shaped area here, and this helps you to control the production of your speech. But actually, even a cursory glance at the basic diagram shows you that there's a lot of the frontal lobe left over there, and it must be doing something. It can't be redundant. And it does. There's loads of functions. One of them is often referred to as executive function, which is quite a difficult concept to sometimes get your head around. But it more or less boils down to your ability to plan and organise things and assess how well things are going. Problem solving is a good way of thinking about executive function, I think. But also the frontal lobe's got a critical role in personality and the way we behave with each other in social situations. And it's also important for something called insight, which is how well we understand what's going on really within our own bodies, but also perhaps being insightful to what's going on with other people. So then moving to the temporal lobe, the bit on the side, well, that's got a primary function as well, and that's hearing. It's principally in charge of hearing. But there's also an area deep in the temporal lobe, tucked right on the inside, which is critical for memory, and particularly making new memories. But once again, there's a reasonable amount of temporal lobe left over. It's not doing nothing, and it turns out it's critically important for language. So naming, knowing the names for things, knowing the meaning of words, but also recognising objects and faces, and from their appearance, understanding their meaning. That's also an important function of the temporal lobe. The parietal lobe, a little bit further back, has its principal job in terms of sensation. So there's an area there, outlined in red, that enables us to have a conscious awareness of what we're feeling on our skin, essentially. But there's a lot more parietal lobe there, and it helps us with tasks such as calculation and writing, spatial awareness, knowing where things are in relation to us, being able to judge distances, and actually a good deal of visual processing goes on in the parietal lobes. Our sense of direction, knowing how to get from A to B, is at least largely controlled from the parietal lobe. So if we know what these areas of the brain do, you can predict what would happen if they're damaged by anything, damaged by trauma, damaged by stroke, damaged by a progressive dementia. So if we were to think, well, what would happen to the frontal lobe if we damaged it, I guess you'd expect alteration in behaviour, particularly that sort of somewhat difficult to pin down social behaviour, the way we interact with each other. One might expect that to change. One might imagine that a personality could be different, and it might be different in lots of different ways. So people could become very apathetic. They might not want to generate much thought or action. They might become disinhibited. They might start to behave in a way that they didn't used to, or that we would normally consider to be socially a bit odd. Or they might behave in a very repetitive manner. You'd expect their problem solving, their executive function to be impaired, and depending on which bit of the frontal lobe is damaged, you might reasonably expect a change in somebody's speech. Because of the frontal lobe's role in insight and understanding what's wrong with yourself, or recognising what might be wrong, a lack of insight, something we could predict. Moving to the temporal lobe, well, it's very important for naming, so perhaps there'll be a difficulty getting the names for things, or understanding the names or the meaning of things. Your knowledge of what words are, what they mean, what they represent, would probably become degraded. You might fail to recognise objects, you might fail to recognise people from their face. And actually, there'll probably be some changes in behaviour, and temporal lobe damage can cause behavioural change, particularly obsessional type behaviours or very routine bound behaviours are strongly associated with damage to the temporal lobes. And I guess for a lot of people in the room who are touched by frontotemporal dementia in some way, as we've seen lots of different ways from the audience, you'll recognise quite a lot of these areas, not all of them, because as we've said already, there's a lot of variability in what could happen with damage to the frontal or temporal lobes or both. But actually this starts to look a lot like a list of things that happen in frontotemporal dementia and the related conditions. So this is a sort of classification scheme that I like to use. Other classification schemes are available. But I found it helpful. So I sort of use frontotemporal lobar degeneration as an umbrella term. So this is just any degenerative disease that's progressively affecting the frontal and temporal lobes. And I'm not going to talk in any great depth about the different pathologies that you can see under the microscope. What I'm going to talk more about is the pattern of symptoms that emerge as a result of these illnesses. So we would call those syndromes in the clinic, or sets of symptoms that can then be turned into a diagnosis for somebody. And the commonest one is frontotemporal dementia, which is what we've been hearing about, what we're talking about predominantly. But there are closely related conditions that it's worth mentioning as well. So whilst frontotemporal dementia is the most common semantic dementia, which is a sort of more of a temporal lobe disorder, would be the next most common. And then you've got a much more focal disorder affecting speech, which once again has got a few different names, but I normally refer to it as progressive non-fluent aphasia. And as we've already heard, some people will call FTD behavioural variant FTD or Pick's disease. That's absolutely fine. Some people will call semantic dementia semantic variant primary progressive aphasia, which is a mouthful. But you know, this is the sort of words that people will use. And by the same token, with the PNFA, progressive non-fluent aphasia, some people will call it a non-fluent variant of primary progressive aphasia. So these are the sorts of conditions and the names that they're given that I think we're talking about. So just to go through them individually, just to describe what happens. So frontotemporal dementia, it is an early onset dementia compared to, if you like, your typical dementias, like Alzheimer's, which overall does affect older people. So the majority of people with frontotemporal dementia develop the illness between the ages of 45 and 65, which is often devastating because these people who are developing the illness are still at work often, and they're often responsible for their children still. So it's a very difficult age to develop a dementia at. That having been said, we increasingly recognise older people with FTD as well, and we're now more routinely diagnosing patients in their 70s and 80s with FTD. What we see is a shrinkage of the frontal lobes, and actually that's helpful because it does show up on tests we can do in the clinic. So think brain scans. So this is a brain scan of somebody who's got FTD, and it's a slice of the brain. You can imagine if they were lying in the scanner, the slices would be like this through the brain. And their nose would be pointing upwards, their head would be in the scanner, their feet would be out towards you, and you can see a slice of their brain. So the front part of the brain has got a lot of black around it. This black is spinal fluid, cerebrospinal fluid, which bathes the brain and the spinal cord. And there's far too much at the front compared to the back, and that's because there's been a shrinkage of the front part of the brain. And this is a very common finding in patients with frontotemporal dementia. It can be inherited, and somewhere between 20% and 40% of people coming to the clinic with frontotemporal dementia describe a family history. So one of their parents, or an uncle, or a great-grandparent, or grandparent, seem to have a very similar illness. Now, it may not have been diagnosed as FTD, particularly if it was a grandparent, but actually a lot of people do describe what seems to be a family history. And of course, as we've already mentioned, the principal symptom that brings them to our attention is usually an alteration in their personality, the way they're behaving, or way they're, going about their everyday task. They're struggling to get by much more than they ever were. We actually sort of split the behaviours up, and we now think about 6 principal areas of behavioural change, and these 6 areas of behavioural change are actually the way that the condition is diagnosed. So if you wanted to apply so-called diagnostic criteria, these are the areas of behaviour that you'd ask about and specifically look for. So you'd ask about disinhibition. So this is somebody behaving in a way, often in public or in a social circumstance, that you think is a bit out of the ordinary, certainly a change from the way they were before. So when you start as a neurologist doing cognitive neurology clinics, it comes as a bit of a blow that your patients don't always just love you for your animal magnetism. Some of the patients are disinhibited and they're kissing you because of that. Some patients have a lot of apathy. They don't do much. They don't generate much thought. They don't generate much deed. And that's very, very disabling. A lot of patients with FTD exhibit a loss of sympathy or empathy. They really can't put themselves in the shoes of someone else. They find it very difficult to work out when someone else is sad or when someone else is angry, particularly difficult for patients with FTD to recognise negative emotions in other people. And you can imagine how much difficulty that causes in a household or in any sort of social setting. We see quite a lot of unusual behaviours, very stereotyped behaviours, people being obsessed by time, having to do things at certain times on certain days. Changes in the way that people eat are common. Frequently people develop something of a sweet tooth, having never had it before. And quite often people start to eat more than they used to, and even stuff food into their mouth when there's still food in there before they're swallowing it, and it can lead to problems. And as we've already mentioned, there are problems in thinking itself, not just behaviour, so problem solving. So we can administer tests in the clinic to try and measure people's ability to solve problems, their mental agility. So this is a test where instead of reading the word yellow, yellow, blue, blue, you have to say the colour of the ink that it's written in. So you have to say green, yellow, blue, red. It's a difficult test. So you have to inhibit the desire just to read the word. And this is one of the tests that's sometimes used in diagnosing frontotemporal dementia. So turning then to semantic dementia, well, once again, often quite an early age of onset, but probably rather broad, and we see people in their 50s, 60s, 70s coming to the clinic with semantic dementia. The part of the brain where the burden of disease falls is a bit different. So rather than seeing lots of shrinkage of the frontal lobes, we tend to see shrinkage of the temporal lobes, the side bits of the brain. So this is a very similar sort of brain scan to the one I showed you previously. The patient's in the scanner, they're lying, they're facing upwards. You can actually see their eyes at the top looking up, and their feet would be out towards you. And the side of their brain is become very shrunken, and that temporal lobe has lost a lot of volume. There's lots of black around it, which is that spinal fluid. This disease doesn't seem to really be inherited. We very rarely, if ever, see patients coming with a strong family history of this disorder. And actually, they have slightly different symptoms. So a lot of language symptoms, as you might predict from a problem affecting the temporal lobes. People are really struggling to get the names for things. They're struggling to understand words. They're struggling to recognise faces, objects. But we see a lot of behavioural change in the condition as well, particularly obsessive behaviours, repetitive behaviours, people becoming extremely preoccupied with an increasingly narrow range of interests. Then we've got progressive non-fluent aphasia. I've just said average age 65 at onset because I think I've seen probably the widest range in some ways of ages in this condition. I've seen people presenting in their 40s, and I've got people with this illness who are in their 80s. So it's incredibly variable. You see shrinkage of the language areas. And as we said, that language area was in the frontal lobe, just sort of tucked down in the bottom of the frontal lobe. But there are other language areas all distributed around that part of the brain. But it can be quite difficult to spot on scans. So this is one of the patients who came to the clinic with a progressive non-fluent aphasia, and their brain scan had been reported as normal by the X-ray doctors. And it looks pretty normal. If you really strain, you use, the eye of belief, you can probably say there's a little bit more black spinal fluid around the left side, annotated by the little L, the left. So maybe that's some subtle shrinkage of the language area, but this is very hard to spot on scans. And actually, when patients first come to the clinic, the scans can genuinely look very normal. We do see some inherited cases, but that's not the norm with this condition. It's an unusual feature to see it inherited. And obviously, as the name suggests, really, this is a problem in speech production. So patients are often very aware of their problem. Everyone around them is aware of their problem. They just can't get words out. And there are lots of variations. There are different ways in which people's language can break down. But often it is a frustrating experience that people can't get their words out. So broadly speaking, what do we know about these diseases? So moving away from the sort of, the pattern of symptoms, about the biology of it, the pathology. Well, we know a bit about the brain, I'm happy to say. So this is actually a slice of brain tissue. And around the outside, you can see grey matter. This is the thinking bit of the brain, more or less. And in the inside, the lighter colour area, that's white matter. So the grey matter does your thinking, your white matter does the connecting, and connects up all the different areas. It's an oversimplification, but it seems to just about hold true. And it's probably the grey area that we're perhaps most interested in with these disorders. That's where a lot of the pathology is. But if we look inside the brain in more detail, use a microscope, that grey matter is not a strip of grey tissue. It's a highly organised, multi-layer, complex organ. And if you look at it with an even more high-power microscope, you see that it's not just layers, it's layers of individual cells, brain cells or neurons. And it's at this level that the diseases we're talking about seem to be having their impact. So all the conditions we've talked about so far, all these frontotemporal lobar degenerations, FTD, semantic dementia, progressive non-fluent aphasia, they are neurodegenerative conditions. This means they start gradually and they progressively get worse. And what is a common theme amongst these neurodegenerative diseases is that within the brain cells, in the affected area, abnormal proteins start to collect. The proteins start to get a bit sticky, they start to clump together, and once you're getting clumps of proteins in brain cells, the brain cells can't do their job anymore. And eventually the brain cells perish. And when enough brain cells in a connected area of the brain perish, you can actually detect that as brain shrinkage. So the brain shrinkage we're seeing on the scan from the patient I showed you earlier is evidence that those frontal brain cells have all become affected by this protein accumulation over time, building up and causing damage. As already alluded to, we know that some of these conditions are genetic, and we actually know some genes that cause frontotemporal dementia. We recognise 3 main genes that cause frontotemporal dementia, and somewhat irritatingly, like all genes, they've got difficult to remember names. They're always given abbreviations. So we've got a gene called MAPT or MAPTau, we've got a gene called granulin or progranulin, and a gene called C9orf72. And these are now available as diagnostic tests for people who've got frontotemporal dementia and appear to have a family history of it. We also know that frontotemporal dementia doesn't always occur in isolation. It can be linked to other neurological conditions. And perhaps the link that's most well known is the link to motor neuron disease. So motor neuron disease is another neurological disorder, and it's characterised by muscle wasting. So patients with motor neuron disease develop weakness, often first in one hand or one limb, but then it spreads, and it's an aggressive disease. And we see now that some patients with frontotemporal dementia develop motor neuron disease. It can happen in our clinic. We recognise it and we try to look out for it. But similarly, we have patients in the MND clinic who my colleagues ring me up and say, I'm a bit worried about this patient because we've been seeing them for their MND, but they've started to behave in a really different manner to that, how they started off. And then they come to our clinic. And in fact, we now routinely share patients amongst our MND clinics and our dementia clinics, which I think is a change from a number of years ago. So that's what we do know, at least some of what we know, but what don't we know? And that's the issue, really. There's a lot of stuff that we don't know. So actually, we don't really know why these proteins accumulate in brain cells, which is a shame, because that would seem like an ideal way into treatment. If you could work out why they're accumulating, maybe you could stop them accumulating. And it's not always entirely clear why they cause damage. The proteins themselves are normal proteins, but they're accumulating in an abnormal way, and how they cause damage, once again, isn't completely clear. Bit of a shame, because if we knew that, it would be another potential opportunity to design drugs, I think. What about the genes? Well, we've recognised the genes, we've identified them, we can diagnose people with a gene problem, we can do the test, but we're not entirely sure what all of these genes do. There are a lot of genes, it has to be said, and the function for all genes is unknown. So why some faulty genes cause dementia remains, unfortunately, a mystery. Another big problem with frontotemporal dementia is that it's difficult to spot. The initial symptoms are subtle, very subtle. And what we'd like to be able to do is spot it much sooner, because all of those scans that I've shown you, those frontotemporal scans with the shrinkage of the frontal areas of the brain and the temporal areas of the brain, those were scans from patients who came to my clinic on day one. That was their presentation. But you can see from the scan that this has been going on a while. A lot of brain shrinkage has already occurred by the time they come to my clinic to receive their diagnosis. In an ideal world, if you had treatments that you wanted to test, you'd probably want to see people at the earliest possible stage when they'd suffered the least damage to their brain. Of course, we don't have a treatment at the moment, but things are moving in the right direction, and we do need to work out better ways of treating this condition. We do know that the available drugs for other dementias, for instance, drugs for Alzheimer's disease, don't really work for this condition. So, work to be done. So how do we answer these questions? Well, I think the answer is research. And the great news is we're going to hear a lot about research today. A lot of the upcoming talks are talking about that. And there are lots of different ways in which people with FTD or related conditions and family members of those with these conditions can participate in research. So there are clinical studies to do with examining the symptoms that we've been describing, about working out better tests for these symptoms, better ways of measuring change over time. That's critically important if we want to test drugs in the future. There are genetic studies So people can give blood samples or other tissue samples to understand more about what these genes do, or even try to look for new genes that might cause these illnesses. There are brain imaging studies. This is a picture of something called a PET scan, which measures metabolism. It measures how much glucose your brain is using. Glucose is the fuel for your brain. This is a scan of somebody with frontotemporal dementia. It shows that the back of the brain is red hot, working very nicely. But the front of the brain is cold. There's not very much uptake. There's not very much glucose being used. And there are many different sorts of brain scans that are under investigation. Once again, we need better scans to detect the illness sooner and then to track change, particularly if we want to intervene and give a drug and then work out if it's working. There are other sorts of samples that people might give in research. There are blood samples to look for evidence of disease in the blood, tests or measures of change, or even spinal fluid samples. So people can undergo a lumbar puncture, and measures, and their spinal fluid could be analysed to look for clues as to why their disease is happening, or a diagnostic marker for their disease, or a way of tracking their disease over time. And quite a lot of patients in our clinic with frontotemporal dementia decide to donate their brain after they've died, which is an enormously helpful form of research. Then the brain can go to a brain bank, and it's available for study so that we can start to get a better grip on why these proteins are accumulating, the patterns, what's happening, and this sort of research has been instrumental in getting us to where we are now. So it's good that for the rest of the day we're going to be hearing a bit about research, I think. So I'm going to stop there. I think I'm more or less roughly on time. This is, for those of you who don't know, sunny Salford. So thank you very much.